Good morning, everyone. This is Diane Perez. And on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Managing Vicarious Trauma. This webinar is being made available through a collaboration of Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. It's so great to see so many people from all over the state to be with us today. And we do have some visitors from out of the state, so that is awesome, and thank you for joining us today. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. This way, both the presenter and I will be able to see your questions. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options have been posted in the chat channel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording of materials used in today's presentation will be available on the FADA website within 10 business days and a recording on the fada.org website. Also, a PDF version of this PowerPoint presentation will be emailed to participants. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families to help participants track credits earned through attendance. We host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Thursday, September 26th. If you do not receive this evaluation in your inbox, please email me at diane@floridabha.org. If you do not receive this evaluation by the end of close of business today. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar We are not permitted to provide partial credit. And now I would like to introduce our presenter, Dr. Heidi Kraft. She received her Ph.D. in clinical psychology from the University of California, San Diego, and San Diego State University Joint Doctoral Program in Clinical Psychology in 1996. She joined the Navy during her internship at Duke University Medical Center and went on to serve as both a flight and clinical psychologist. She currently serves as a clinical director at PsychArmor Institute, a national nonprofit that provides free online education for those who live with, care for, and work with military veterans. She is frequently invited to speak at conferences and panels on combat stress, stigma, and caring for the caregiver. She is a lecturer at San Diego State University, where she teaches stress, trauma, and the psychological experience of combat, as well as health psychology and abnormal psychology. I'd like to welcome Dr. Kraft.
Hello, everyone. It is a pleasure to be here. Thanks, Diane. So, of course, I would go an entire calendar year without getting any of the germs that my children bring home from school until yesterday. So I'm sorry for the voice. I have water next to me and coffee, and I will do my very best to project and not to cough, but I appreciate in advance your very patient empathy as I try to kind of navigate my voice. So I have control now, I think, Diane, I'm pretty sure.
You should open up the thumbnail view to be able to move the...
Up in the right-hand corner?
On your left-hand side, yes, of your...
Oh, left-hand side, got it, yep.
Okay.
There we go. Okay, and then I should be able to move through there, right? Okay. Okay, so as by way of introduction, as Diane said, I'm Heidi Kraft. I'm a clinical psychologist. I was very honored to serve our country for almost 10 years on active duty in the U.S. Navy, and have since then had my career shift a little bit. I think I started off in my training in health psych, really behavioral medicine, and fully intending to work in a hospital setting with medical patients. I did my internship in heart and lung transplant, being the psychologist on the transplant team, with every intention of taking that road really for the rest of my career. And along the way, a funny thing happened. I was the daughter of a Navy submarine officer who had always tried to convince me that the Navy was really the way to go, to let them help me pay for school. And I didn't want to do that when I was young, of course, and kind of avoided that as long as I could. And then one day, I was in the middle of my internship at Duke and woke up, and I had this really kind of strong realization that turned out that I needed to serve my country. So things changed for me. I was able to continue to do some health psychology throughout the years, but I really did take a shift into the world of flight psychology in the Navy, which is a really performance-based.
No.
Is someone speaking? I'm sorry. Okay. Anyway, sorry about that. So anyway, that's I'm making this too long, but the bottom line is, in my things shifted for me, and the time that I had, which was on active duty, ended up kind of focusing in trauma in a way that I wasn't expecting. Obviously didn't expect to go to war, didn't expect that experience, which was the best and worst experience of my life at the same moment, but really did love my time in the military and had my focus really shift at that point to thinking more about trauma. And I became an expert, if you will, in PTSD and vicarious trauma through a lens. Since then, there's been a lot of speaking and writing about these topics, and continue to really enjoy working for our country's veterans, their families, the people who care for them, like all of you, community providers who may have veterans in your practices. Obviously, the content we'll be talking about today is not veteran specific, but my case studies are simply because. So that is by way of introduction. So today we will be discussing what we call secondary traumatic stress. There are other ways to kind of think about this, and I will go over that and define those. But there's a couple different kind of levels that we might be talking about. We could be talking about burnout, or we could talk about compassion fatigue. At a higher level, we might be looking at secondary traumatic stress or even PTSD from the point of view of the caregiver in behavioral health professionals, as well as the kind of point of this webinar, I think, is to give those of you that are supervisors a little bit of additional insight maybe into some of the people that you might be supervising and helping as they begin the journey of treating trauma. So I'm trying to, there we go. So we will be talking about what it's like to experience the treatment of people with trauma, what this work is like for us as professionals and as students who are beginning this work. We hope that this training will also allow future behavioral health professionals the idea to kind of give themselves permission to have this work be hard and to know that it will come with its challenges, but also its great rewards. Many of you will be and are working with people who have high levels of trauma exposure. And while that work can be incredibly professionally fulfilling, helping people to move through their trauma journeys, it can also take its toll on us as providers. So the learning objectives for today. We like to think that by the end of our time together, all of you should be able to talk about shared trauma and describe the elements of what we mean when we talk about shared trauma between a provider and a patient. We should be able to explain things that supervisors can do to help their supervisees move towards something we call compassion satisfaction, away from the idea of compassion stress and compassion fatigue, and more towards compassion satisfaction. And then to understand the complexity of what we call moral injury or inner conflict in traumatic experiences. The people that you serve and take care of may have experienced pretty complicated traumatic experiences. And some of those elements that we treat as we treat trauma might include, and oftentimes do include, moral injury. So I'll be going over that a little bit, giving you a case study about moral injury and how that might be playing into the work that you do and the way that you care for people. So to start here, we have a poll, which I think, Diane, you have the way to have this happen. So you see it here. How many of you provide care for individuals or supervise those who provide care for individuals who have experienced trauma? And your answers are that you do or that you do not. So if you could answer that poll now.
So we'll keep the poll open for another 30 seconds, and then it'll take about 30 seconds to pull the data together, and then I'll share. So we have 132 that says I do, and then 12 that says I do not.
Okay. 132 and 12. Okay, terrific. It sounds like many of us then have very similar experiences, that the work that you do includes trauma. And this is not a surprise. Many of us as clinicians, especially those of us that are working with people who might be struggling with problem substance use, the people who come to our care often have lived through traumatic experiences. I will be reviewing that, what we're talking about there clinically, and what we need to be looking at as far as our conceptualization of that. But I think going forward in your clinical time, it's a nice way to proceed as providers, sort of from a trauma-informed lens, thinking that probably most people, if not all, have lived through something that might be diagnosed as traumatic at some point in their lives. It is, of course, subjective, and people will experience that differently, but most of us have been through something, and many of us have recovered naturally through time without getting stuck in that recovery process and needing additional experience, additional professional help. Some of us through that recovery without needing to self-medicate or to turn to other behaviors that are damaging to our health. And some of us don't. So many of the patients that are sitting in front of you, the people that come to your care, will have a history of this. It's a reasonable thing to assume that most of them will. So I think we can proceed thinking that way. And okay, Diane, we're ready, I think. Can't make it move. Okay.
1 second.
I'm trying to click on, there we go. Okay, nope, I want to go back. Shoot, sorry guys. It wasn't moving, and then when it started moving, it moved completely. Okay, I'm going to share with you a case study. This is actually a chapter that I wrote from a memoir that I wrote about my time in Iraq, which was in 2004, with the Marines in a Marine Corps surgical company. I'll be sharing with you a couple different case studies, which are chapters from that memoir. And this particular one, I thought it would be kind of cool to, instead of tell it to you myself, to actually share with you a clip from the course that has been developed here at PsychArmor, based on our experiences with vicarious trauma and compassion fatigue. We have free online courses for people who support veterans in lots of different ways, including healthcare. So this is a clip from the course, The Cost of Caring, in which I discuss vicarious trauma and ways that providers can take care of themselves and best serve their patients. This is a clip from that course, which will then allow you to hear this case study. start this module by telling you a story. In the States, football season. In Iraq, the only signs of autumn were high temperatures just slightly lower than the summer's peaks of 132. Our sea bags were ready to go. Our flight home was scheduled. My psych tech introduced my last patient to me and left the room, closing the door behind him. The gunnery sergeant's arms stretched the fabric of his desert utility uniform taut. A pistol was strapped to his right thigh. "Good morning, Gunny," I said, extending my hand. "Morning, ma'am." He gripped my hand tightly and looked straight through me. We both took a seat. "Petty Officer Bob tells me you're experiencing some difficulty sleeping lately." "Yes, ma'am." "Nightmares too, I understand?" He nodded. "What can you tell me about what's going on?" His light blue eyes appeared distant and glassy. He exhaled sharply and looked at the floor. "I was standing in front of the exchange the night of the first attack," he said. "When that first rocket came in, shrapnel hit several of my Marines. I remember I looked at Corporal Overton and he was just lying there. He wasn't moving. I couldn't tell if he was breathing, but I knew it was bad. There was blood everywhere. I threw him over my shoulder and carried him to the hospital. It's about 200 yards, but it felt like 2 miles. I yelled for someone to help me, and a few corpsmen ran out, put him on a gurney, and took him inside." "What did you do then?" I asked. "I just sat there. I didn't know what to do. It was so crazy, I felt like the only thing I could do was get back to my unit. So I left. I left him there, too." He swallowed hard and lowered his gaze. I nodded. I remembered. I had seen Corporal Overton's body in the basement of our hospital that night, the first of many nights during which rockets pounded our base. His boots had been removed and were neatly placed at the edge of his gurney on the dusty and cracked tile floor. A scratchy green wool blanket covered his body to his stretched his fists into open hands and turned them up. He lowered his face to his palms and began to sob. Pulling with the heels of my boots, I scooted my chair across the floor until I was sitting squarely in front of him. In a gesture unlike anything I've ever done in a normal therapy situation, I reached out and touched his hand. He looked up. I took both his hands in mine. There was nothing normal about this situation. I remember Corporal Overton, Gunny, I whispered to him. We all do. His death touched us, and we'll never forget him. He was our hospital's first KIA. How could we forget? I'm so very sorry, I said, for your loss. He stared at me. We sat in silence, battling different images of the same young man's death. Thank you, ma'am. He was still clutching my hands. In the beginning of my deployment, there were tears of loss. Today, my eyes were dry. Early on, there was a deep ache in response to my patient's distress. Today, my nerves were deadened. As a clinician, I knew that human beings develop coping mechanisms to adapt to chronic trauma. I realized emotional numbness had become mine. At least my patients could still cry. Thank you, Diane. Okay. Back to my, that is a case study for what one might be able to pretty easily say demonstrates compassion fatigue or vicarious trauma, some of the various concepts we'll be talking about today. It was an incredible 7 months. In many ways, we were unprepared for what we found there. Early on in Operation Iraqi Freedom, so we deployed expecting to provide humanitarian aid and definitely not expecting the number of casualties that we took and that we treated and how dangerous the deployment would be for all of us. I think that as a provider, it taught me a great deal about my capacity for holding my patients' stories, for my ability to manage those stories in the face of my own fear and vulnerability. It was a very unique situation. And I think it gave me a way to think about treating trauma in a way I would never have expected. I learned what I had to do, but I also learned firsthand the toll that it took. That particular case is unique because it happened to be the last patient before we left to go home. So I was also looking at a cumulative effect, which we will talk about today, because just like our patients have cumulative effects of a lifetime of traumatic experiences, we would tend to have people who come to us after combat or after sexual assault or after natural disaster, after a bad car accident, after interpersonal violence. We talk to them, we get a history, and we learn that maybe they've also experienced a traumatic childhood. We would expect those events to have a cumulative toll on our patients, and that their experience of post-traumatic stress disorder might be more complicated, might be harder for us to figure out how to navigate if we're talking about that cumulative toll. We have to realize that as providers, we are no different. That the more we hear these stories, the more these stories touch our hearts, and the more work we do in this field, the more that this has the potential to affect us. So a couple things to think about when we kind of think about that story. I think at the end of that particular chapter, I said something like, it was obvious to me that I was a casualty too. I've been treating casualties for 7 months and had seen some pretty horrible things, had seen some pretty amazing things, some moments of courage and friendship and loyalty that I could never have imagined existed, and also some real horror and terror and fear for my life, fear for my patients' lives. So it was a intense and amazing and horrible experience, as many of the experiences that your people will bring to you will be. So I had the unique opportunity about 10 years ago to meet and present with Dr. Charles Figley, who is, many of you know, if you know this literature at all, is really thought to be the father of compassion fatigue. He really knows this world. He was a Marine and has gone on to write a great amount about our veterans, but also lived in New Orleans and wrote a great deal about, after having been a provider after Hurricane Katrina, wrote a great deal about kind of providers in the middle of a shared experience. So a lot of what I'll be presenting to you today about this and what we know about this literature comes from Dr. Figley. So he basically says that there are 4 reasons that those of us who work with people who have experienced trauma experience vicarious trauma ourselves. And they kind of come down to empathy and exposure. So if we had to kind of put them into a larger category, we would say this is what makes us at risk: our empathy and our exposure to traumatic stories. So first of all, empathy. Obviously, I'm talking to all of you knowing that you are providers. We attempt we always attempt to look at our patient, sit with someone in the moment as that person is going through something. We attempt to sit with that person, trying our best to put ourselves in that person's shoes as much as we can. This is called empathy. And we try to have it as we treat everything, of course. And this is who we are. We try our best to deliver this as we sit with our patients. It's extremely important in the treatment of trauma. As you sit with someone who's been through something horrible, that person knows whether you are trying to understand that experience or not. So this is the way we are good at this work, right? The best of us who treat trauma are those that can be the most empathic in that moment. And those that our patients know, we're sitting with them. We may not have experienced the same thing, but we're willing to go with them on that journey. We're willing to try to understand what that was like for them. That's empathy. It is the most important part of being able to treat trauma, and it's the primary reason that we have secondary or vicarious trauma. Here's number 2. Many people, those of you out there, there were 132 of you who said yes, that you have experienced, that you do treat people who have experienced trauma. Many people who work in these roles and who treat people who have experienced trauma have also experienced some sort of trauma themselves. So we won't ask this as a poll question, but poll yourselves within yourself. You're doing this work. You're with people who have lived through something awful. But have you lived through something awful yourselves? And almost all of us, when we've been doing this for a while, when we've lived a life that's been full, we are able to say honestly that yes, we have. We have lived through something difficult. We might have experienced a horrible car accident or a natural disaster or interpersonal violence or child abuse. And as we have to turn those lenses in a little bit and see that yes, this is part of who I am as a provider. It's part of what brought me here. Number 3, this unresolved trauma in the clinician will necessarily be activated by the stories that he or she hears. So now, if we have been honest with ourselves and we've thought about this, can I look inside and say that yes, this is where I've come from, that I have also experienced something traumatic myself, that something was difficult in my past. I can easily look at that 7.5 months in Iraq and very honestly let you know that many of those days were extremely traumatic. Of course, I was taking care of severe injuries and saw a lot of horrific wounds, but it was more than that. It was also truly fearing many times for my own life. So I think that being able to know that about myself was important. And as I sit with my current patients who have experienced something, who have experienced trauma, I know I'm coming to sit with them that day, coming to their treatment with those experiences. Now, personally, I have received treatment for a lot of what happened in Iraq. But any part of it that's unresolved for me, or even some of it that is resolved, still could be very activated by some of these stories. And it doesn't need to be the same type of trauma. If you came from a history of childhood, you were treating combat trauma, you might find yourself being really activated by hearing some of what your patients are bringing to you. So this is the other kind of another piece to why we know that some providers struggle. And then finally, children's trauma is especially difficult. And even those of us that really specialize in pediatrics and have been through training that has taught us how to deal with children and how to deal with the stories that they tell and the situations that they live through, it's still very difficult for us as adult providers to hear about children being traumatized. We know this. This is kind of just who we are as people. We're other focused, and it's difficult to hear anyone feeling trauma, but especially children. So we know that when we start to add that piece, that this adds an additional burden for us. For many of my patients who are combat trauma veterans, who have experienced combat trauma, a lot of their stories will include children and include the difficult experiences that they had in war with seeing children injured or killed and feeling a real connection to their own children as parents. I think that happens to us as clinicians too. So as I'm sitting with my Marine patient who is talking about having an experience with a child in combat that was holding an M16 and pointing it at him, that experience for that Marine is a lot of what he's struggling with. But as a clinician, as a mother who had young children, I struggle with that too. I see a comment that just popped up saying countertransference. It's so true. It's our stories. It's what we bring from our past. And certainly that piece about children is real for many of us, whether we're parents or not. We all, I think, as humans, as clinicians, we struggle with this. Okay. So let's talk a little bit about, we're going to now just kind of define the different levels of what we might be experiencing. There are different terms that we use for different levels of these experiences in clinicians and the way that they present. So let's talk first about burnout, because many times we hear people talking about burnout in medical providers of a lot of different types. There's a very large literature in burnout. Specifically, interestingly, a lot of that literature focuses on nurses. When I started to prepare for this talk, and obviously I've spoken about this a lot. I think Diane mentioned that when she introduced me. I've had a chance to present with Dr. Figley a couple different times. And when we talk burnout, a lot of that literature is based in our wonderful nurses and what they struggle with. But this could affect any of us. Basically, when we talk about burnout in us, in behavioral health clinicians, we're talking about exhaustion. And it can be physical exhaustion, of course, but more so we are discussing here emotional and mental exhaustion that comes from situations that are emotionally demanding to us. So these situations are asking for our emotions. They're asking us to not go through the motions, but to care. And the exhaustion that comes from that is what we call burnout. In burnout, we are talking about a process. So this is something that probably is pretty insidious. It probably starts gradually and moves through a person's clinical experience, getting worse with a cumulative effect. So rather than an acute experience or something that starts with a person and doesn't change, burnout seems to be on a trajectory that gets worse with time. What we hear people say who are struggling with burnout is that they don't feel the reward in their work that they used to. They feel a lack of that self-efficacy, a feeling that they're making a difference, the achievement that they used to feel for their work with their patients, that starts to go away and they feel kind of numb about the work that they're doing. So that is what we mean when we talk about burnout. Burnout is cumulative. As I mentioned, it tends to get worse over time, and it's predictable. For nurses who are working in the ICU, we see people who are really very, very physically and emotionally and mentally injured, and many of them are not getting better, and the work that they're doing is not helping. This is kind of what nurses are saying. Many times on med-surg wards as well, the literature is full of nurses saying that they know that it's to be expected, that many of these patients are very sick, that the work that they're doing, that caring about them emotionally is what they're trying to achieve, but that sometimes that cumulative toll causes them to feel like they're not making a difference. And while they could say, yeah, I would predict that, this is hard work, it still doesn't make it any less difficult for them. The very classic measurement for burnout is the Maslow burnout inventory, which has been around for a long time. There are a number of other scales out there, but this still tends to kind of be the gold standard. And in this inventory, which is available online, clinicians take a series of questions, and it measures their emotional exhaustion, but it also measures their depersonalization, which is an interesting piece of the burnout. But it basically means that as we get more burned out, we tend to think of our patients less as people, and kind of we start just going through the motions and having less of an emotional connection with them, as well as with ourselves. We think of ourselves less as people as well. We kind of pull ourselves back from the connection that used to matter in that work. And then finally, it also measures, like I was talking about before, reduced personal accomplishment, feeling that we are not, in fact, making a difference where we used to feel that we were. So that's kind of what we're talking about when we're talking about burnout. Another term that you might hear when you're learning about vicarious trauma or thinking about vicarious trauma is compassion stress. So where burnout is a process that's cumulative and predictive and tends to get worse with time, compassion stress is more what we might define as the cost of caring. So my friend Dr. Figley defined this back a while ago, saying that it is the natural, preventable, and treatable consequence of working with suffering people. I love this, and I would never be able to say it better myself, so I thought I would just quote him. Basically, this is the demands that we perceive as we experience other people's suffering. So our demands, the demands that we experience as we treat those people, we're trying as providers to help relieve that suffering in some way. That's what we're attempting to do. What our goal of treatment is, we want to help our patients suffer less. And the demand that puts on us is what he's talking about with compassion stress. We move on from there to vicarious trauma. So kind of we're moving on a continuum here. When we talk about vicarious trauma, now what we mean is the exhaustion and traumatic stress associated with the suffering of the individuals in your care. So differently than just wanting to help people who are suffering, relieve that suffering, vicarious trauma then begins to be the experience of traumatic stress in yourself. And this is associated with your patient's suffering. So we start to absorb the trauma of people that we care for. And this is, as a result of doing this work, it can happen very suddenly, and it can happen without warning. So you might be moving along, treating your patients who have experienced trauma, feeling like you're doing a good job and that the work is rewarding and that your patients are feeling better and you're a part of that. And then suddenly, really without any warning, you can start to experience traumatic stress yourself. The symptoms that might come along with this could include symptoms such as helplessness and feeling really confused. People who might start to have these symptoms, providers, they might start to isolate themselves from the people that would be able to provide support for them. We can also hear this experience called secondary traumatic stress. You might see STS in the literature, that's secondary traumatic stress. It can be called compassion fatigue as well, and you may have heard it discussed as that. The bottom line is these terms are interchangeable, but what we're looking at here is where the trauma actually begins to affect the provider, and the provider starts to have symptoms of that trauma. So let's review what we're talking about. We're talking about trauma. For many of you, this is a review, especially if you work with people who are suffering from trauma. But in the DSM-5, trauma is defined and diagnosed as a real or perceived personal threat. So as you know, the DSM-5 has changed this a little bit. We have that real or perceived threat now being towards life, towards serious injury or towards sexual violation. So we can be actually threatened in one of those areas, or we could perceive that we're being threatened in one of those three areas. Of course, we can also witness this happening to someone else. So these are ways that if a patient tells you a story, you are first and foremost determining, am I looking at a trauma? Of course, in addition to those two ways, either direct or witnessing, you can also hear about this experience happening to someone that you care about. Those of you that know this criteria know that this one's a little tough, because we'll often have people ask the question, well, what about someone with a long protracted illness that was difficult and that person finally passed away? Is that trauma? The DSM-5 would say no, because when we learn about something happening to someone we care about, it's asked that that experience be unexpected and violent. So we're not typically talking about a long-term, drawn-out experience, but more something that's sudden and unexpected. And then the fourth way that you can experience a trauma is hearing about it through secondhand experience. So here we are. This is where we fit in the experience of trauma. DSM-5 has a place for us, and that's when repeated exposure to traumatic stories is heard. So we're talking about us, we're talking about clergy, we're talking about first responders who are in these roles, and where the experience of hearing the story takes a cumulative toll. Trauma is complicated. It's, those of you that treat it know. Certainly, every traumatic experience could be different from person to person. What I consider traumatic, many of you in the audience would not. But I think there's a few things that are sort of universal. And those of you that have taken care of people who have been traumatized know you can sort of look in someone's eyes and really be able to tell whether that experience haunted them, whether it stayed with them, whether it caused them that great fear that we're talking about. There are a couple of different types of experiences that we've now learned can lead to trauma. We could be talking about what we call an impact injury, which is one sudden horrible experience, one horrible car accident, a natural disaster, an episode of interpersonal violence, one horrible moment in a combat situation. The experience that when we're told the story, everyone would agree, oh my goodness, that's definitely trauma. But trauma can also show up in a couple of different ways. It can show up as cumulative fatigue or exhaustion after a long period of time of repeated exposure. So many times we hear this when we hear from people who have suffered from child abuse for a number of years. The way they tell the story sounds like exhaustion. It doesn't sound like one horrible impact anymore, although there were many horrible impacts throughout their experience. It comes across as just being completely worn down and exhausted by the experience. Trauma can show up as grief or loss. It can be very complicated with shame and guilt, but the loss of someone or many people, the guilt of being alive when other people have died, this can be a way that trauma is presented to us. And finally, it can present as inner conflict or moral injury. Many of you know the literature on moral injury. We used to call it moral injury all the time. Jonathan Shea wrote a wonderful book about it called Achilles in Vietnam, which many of you may have heard about, where he really defined moral injury and what we're talking about. The military has gone away from using the term moral injury because they don't want to insinuate that these experiences are somehow mean that the person is immoral or has made an immoral decision. Sometimes they do, of course. You could have those kinds of conflicts, but for the most part, these situations are situations where there's not a black or white answer. Things that you used to believe were right are suddenly not right, and you are having to be faced with that. That suddenly, right in front of you, is something that does not make any sense based on what you know, based on the truths that have always protected you. And so people's beliefs get shattered, their faith gets shattered. And this happens a lot in trauma. This is very common in combat. Remember the situation I told you about earlier with the child soldier that some of my patients had talked about being face-to-face with a kid holding a rifle. That there's nothing in that situation that's right for an American who's grown up treating children with care and respect and not putting them in harm's way. So inner conflict can certainly complicate the trauma story. So as I was talking about truths we held on to that don't protect us anymore, chaos and confusion, shame and guilt, feelings of betrayal, shattered faith, having committed horrific acts, no right answer, or that horrible gray area where it's not black and white at all. I have a case study here that is taken from our course at Psych Armor that I narrated called Moral Injury or Inner Conflict, or I think the course is called Inner Conflict and Survivor's Guilt, sorry. And I tell a story here. Again, this is a chapter in my book, but I tell a story here that I thought I would share with you as a case study. Go ahead, Diane, we're ready for the clip.
I thought I would share a case study that I believe illustrates some of these concepts. A few years ago, I cared for an enlisted medic who was assigned to a Marine Corps Special Operations Unit. As this happened, someone threw a bundle of blankets into the fire. At that point, the Marines were aware that inside the bundle was a baby. The baby started crying as he hit the fire, and of course, just like the people believed they would, the Marines stopped to take care of the baby instead of giving chase. The baby was burned. He was in a lot of pain. And in that moment, my patient needed to function as a corpsman. One of his teammates handed the baby to him and said, "Here you go, Doc. Take care of this baby." And in an instant, he changed from a special ops Marine, part of the team sneaking through the darkness on a secret mission, into a medical provider, a burned baby in his arms, for whom he was trying to provide care. There are so many complicated pieces of this narrative. My patient happened to be a father of young children. And in therapy many years later, he really struggled with the fact that this father would sacrifice his own child in an attempt to get away and stall the Marines. My patient described a great deal of conflict over this situation. He struggled with his faith in a God who would let something like this happen, with his understanding of children being protected by their parents, and of where he fit into all of this, as a father with his own children. He also had difficulty reconciling many years later. At one moment, he was a member of a special ops tactical team, and in the next moment, he was trying to search through his bag for something that would treat serious burns for an infant. It took a long time to process and to understand.
Thank you, Diane. So what you hear there is something that unfortunately is pretty common in the combat trauma scenario, where different expectations for the care of non-combatants cause a great amount of conflict. So we, in our country, believe that non-combatants should stay that way. They should not be involved and really try our best not to include any non-combatants if we possibly could. And we sometimes fight against people that have different strategies there. And so when we have women and children included in combat operations and used as part of what is trying to be achieved in combat, my folks come to me then, my patients come to me with great conflict around that, with not understanding how a pregnant woman or a child could have been involved in a situation. And that causes them to have great chaos in their minds, to really feel that there's no right answer and that they don't know where they stand in that experience. And this is a great example of moral injury. My patient was suddenly asked to care for a baby who had been burned, who had been thrown into a fire so that someone could get away. He struggled with that so mightily, and it really affected him greatly going forward. His symptoms were really based in that story. It took a while to actually get him to trust me enough to tell me that story. But when he did, I realized that was a big part of what he was struggling with. So just an example of inner conflict or moral injury that might sort of complicate a lot of what we're talking about here. So treating trauma in people who come to us. Those of you that do this for a living, you know that there is evidence-based treatment for trauma. There are a series of fantastic protocols with decades and decades of evidence behind them. And we know that they work, that people can really get better and that their symptoms can go into remission. Evidence-based treatment of that trauma includes exposure to the traumatic event. We ask the patient to tell that narrative, whether it is over and over again in prolonged exposure, whether it's part of a written narrative in cognitive processing therapy, whether it is during our experience with EMDR as we're helping the person release some of those sort of conscious holds on the story and let the story be exposed. But at the same time, the clinician is exposed. So as we do these protocols and we see and hear these stories and we see the effect on our patients over and over again, the clinician can be exposed and is exposed. So compassion fatigue or vicarious trauma can result from that cumulative exposure. We don't get to treat that vicarious trauma in ourselves. We just hear the story over and over again. So this is what then can lead to that vicarious trauma in clinicians. So some things to think about with regard to the treatment of vicarious trauma. Those of you, I don't know how many of you have heard of stress first aid. It's been around for a long time. It was developed many years ago, actually, as a specific protocol for first responders. And it's been around for a long time. It's a specific set of steps that we can learn to help people who are undergoing stressful situations. It doesn't have to be trauma. It certainly can be part of treatment for trauma, but it also is just for cumulative stress. There are also steps that have been named in the literature to help providers achieve compassion satisfaction. I talked about burnout, about compassion stress and compassion fatigue, but we can learn to become more resilient providers and actually go on to develop compassion satisfaction. There are steps that have been identified to help us achieve that. And then finally, provider support groups or consultation groups, which can be set up so that you as supervisors can take care of those that you are training to do this work. And each other, frankly. We don't need to just be trainees in order to experience great relief from being around providers who might be doing similar work and might be able to really benefit from telling those stories together and be able to consult with colleagues that might be able to help us think through some of the things that we've been dealing with, help us see those signs of compassion fatigue in ourselves, and maybe some ways to get through that. Diane, I can't remember when we had talked about doing our break. Is it soon? Diane? Well, I thought we had talked maybe about doing a break here, but I will wait until I hear back from Diane because she will be involved in making that happen. Diane, any time now would be reasonable to do the break, so just let me know if you're back online.
Hi, Heidi. Dr.
Yeah.
Heidi, I thought I had unmuted, so let's go ahead and take that 5-minute break.
Okay. Thanks, everybody. This is a good time to take that 5-minute break, and we'll see you in 5.
Dr. Kraft, if you're ready, I'll turn the presentation back over to you.
Okay, so sorry. Okay, so we had been talking about, now that we know what compassion fatigue, vicarious trauma, burnout is, what kinds of things can we do and what kinds of things can we offer those that we supervise? Before I dive in, I did want to just address, I got a question in the chat that says, I believe trauma can also be hallucinations or even delusions that haunt people and may be repeated in their minds. Do you agree? Well, that's a pretty complicated question. I don't know. I think I would need to know more about whether the hallucinations or delusions were part of a traumatic event that also occurred. I'm not sure that the DSM has a way to consider a hallucination in and of itself trauma, but it depends, I guess, on how the patient perceives that. If the hallucination felt very real, I could see that person experiencing it again and again, almost as if it was real. So a pretty complicated question. I think I would probably have to defer that to, I need to know a lot more. I need to have the history, see what else was going on with that. So sorry to kind of defer that one, but thank you for the question. Sorry, I didn't answer it totally directly. I think most of you would understand. Let's get the history first, and then I'll weigh in. So onward. So stress first aid. I had mentioned that this is one way that we can use if you're supervising people or if you're consulting with people who are treating trauma. One thing you can use is stress first aid. And stress first aid is actually a pretty well-established protocol. There's 7 C's. 7 C's is the way you think about stress first aid. And they range from really acute, kind of making sure that the person is safe in the moment, so finding cover. They're a range. But what I kind of did is I looked at them. I looked at the steps that matter to us as providers, especially if we're treating trauma. And I thought that maybe just highlighting a few of those might help you think through this work yourself, as well as those that might be coming to you for your guidance. And those steps that matter to us that really can help us move through these experiences are the 3 C's of connection, confidence, and competence. And so to that end, I thought I would show you, or I'd share with you another case study. This is, again, a chapter in my book, which is called Women's Best Friend. And I thought it kind of illustrated nicely the steps I'm talking about. So I thought I would just share that with you. This is our hospital. It was an old Iraqi Air Force base that we were stationed on when I was in Iraq, in Western Iraq, close to the Syrian border, between Fallujah and the Syrian border. And so this was actually their hospital. It was, it looks like it's in pretty good shape. It really was not in very good shape. The building was, had a whole bunch of holes in it, and it had windows that kept getting broken when they would fire rockets at us. But this was home for about 7.5 months during early 2004. Without further ado, sometimes when a Black Hawk with its bright red cross landed on our pad in a swirl of dust, the patient brought in on the gurney was not a Marine, sailor, soldier, or even an enemy prisoner of war. Sometimes the patient was a dog. The Marines had a large corps of working dogs, beautiful, sinewy shepherds, who aided in the mission in Iraq through the detective of explosives, weapons, and bad guys. Each dog had a Marine handler, and hundreds of these duos were spread throughout the country. The good news was the dogs were treated like royalty, with guaranteed air-conditioned spaces and terrific food. The bad news was sometimes they needed a doctor. Our veterinarian was Army Major Tim Luna, an extroverted man with a warm, engaging grin who had once been a paratrooper. Sharing resources with our operating room and intensive care unit allowed Tim to build a complete animal surgical suite in the basement of the hospital. He knew of my fondness for dogs, so he sent word to me whenever he had a, quote, lover, a working dog that adored being adored. Not all of them fit this category, but whenever a lover arrived at Tim's shop, I found a way to spend some time in the basement, talking to the gorgeous animal while I stroked his head and kissed the bridge of his long nose. In Iraq, I developed a new appreciation for pet therapy. I believe Tim knew how happy I was I had this unique opportunity to escape the desert for a few magical moments with his canine charges, but I do not believe I ever told him how much I appreciated his role in saving one of my patients' lives. Sergeant Hutchinson, a petite brunette with freckles sprinkled across her nose, was a helicopter flight equipment specialist. Like many Marine pilots and aircraft maintenance personnel, she found herself in Iraq filling an unfamiliar role, in her case as a member of an auxiliary support battalion. Grueling convoy duty took its toll on everyone in her company, but Sergeant Hutchinson had two other problems in addition to fatigue and vulnerability. She had a history of clinical depression, and she was the only woman in her company. She came to me early into deployment feeling lethargic, weepy, hopeless, and fleetingly suicidal. The sergeant and I had a heart-to-heart. She did not want to be sent home. Through tears, she begged to stay. Although she worried about how she would succeed, she said she wanted to finish the deployment to prove to both her unit and herself that she could. I believed her. Jason and I worked together, combining antidepressant medication and intensive therapy to teach her to block her self-defeating thought processes. For a while, she made progress and slowly experienced more energy and increased self-worth. Halfway through the summer, the sergeant experienced the loss of one of her friends in an IED explosion. This caused a downward spiral in her functioning that I feared pointed to her medevac. She told me her future was hopeless. She spoke of falling asleep and never awakening. She and I worked long into the evening that day, and I could almost hear her fingernails digging in as she struggled to maintain her grip on her mental health. She held on. The operational tempo of her unit increased, and she was unable to see me for almost 2 months. And then one day, 4 weeks before we returned home, Sergeant Hutchinson strode into our office a different woman. Her hair was pulled back, her cheeks were rosy, and I think I saw a trace of lip gloss. She smiled brightly. I had never seen her smile before. Our unit has adopted this puppy, she started as she sat down. I had heard about several groups of Marines finding the orphaned puppies of wild dogs on the base and making them unofficial mascots, feeding them with shipments of puppy chow sent from home. Everybody liked him, but he always came to me. He sort of became mine. Anyway, I heard that people were talking about sending their puppies home. My heart sank a little, immediately worried that my sensitive patient would be devastated if her plan did not succeed. So I came to talk to Major Lunam. I smiled, proud of her initiative. He's nice, isn't he? Oh, ma'am, he is so nice, she gushed. He took a look at Coco, that's what I'm calling him because he looks like the color of chocolate. Anyway, he gave him all his shots and did the operation to neuter him. And when we did the worm medication too, Major Lunam says he's in great health. I had to admit I was surprised. Tim would never have gone to all that trouble if there was no chance of this woman being able to keep this dog, was there? He said he has a friend in Kuwait who would keep Coco for the 6-week quarantine thing. He said I just needed to arrange to have him sent to Kuwait. So I went and talked to the C-130 squadron, and they said sure, they'd take him. Patients rarely surprise me. I sat and stared at her. So Coco got to Kuwait, Major Lunam told me, and the vet there did all the customs paperwork, and all there was left was an airline ticket. So my mom and dad got that, and they picked him up at the Detroit airport yesterday. They're going to bring him to San Diego for me when we get home. She sat back in her chair, crossed her arms over her chest, and grinned. Wow, I shook my head. That is wonderful news. I'm very proud of you. And you must be very proud of yourself, too. I am, ma'am. You know how you kept telling me to start looking at the goals I had for my life once I got home? Like to find the things I look forward to? I nodded. Well, I figured out what they are. Coco came into my life for a reason. I have to take care of him now. Good for you. And I'm going to apply for the working dog program in the Marine Corps, she added. I figure once you know what it is you love, you might as well do everything you can to fit it into every part of your life. I believe good doctors learn from their patients every day, but I had never expected, in the middle of the desert, half a world away, a female sergeant in the Marine Corps would define a new cure for depression. So, you saw in that story several different things, and I hope to be able to kind of pull them together as we talk about stress first aid and compassion satisfaction. So, what you see here is several different things. Resilient providers, or compassion satisfaction, was also defined by my good friend, Charles Figley, as positive affect, self-care resources, and the social support that matters to us. So the self-care resources he's talking about, interestingly, could also be stress first aid and those C's that I talked about. So one of them might be confidence. This can be in a lot of different ways that we bring those self-care resources to the table. They could be intellectual, the things that we know stimulate us and cause us to be, I think, motivated going forward, the things that will help us stay sharp and on our toes. It could be physical exercise, and in many cases, that's a really important way of managing our work in the trauma field. A lot of times I'll tell people, just walk out the door and take a lap around the hospital. Just getting a little bit of physical activity and fresh air can really matter. Nutrition matters. It is important to, when you're helping your supervisees start to work in this realm, or if you're consulting with someone else, remind them how important it is to take care of your bodies by thinking about the food that you're actually putting in. It matters. If we're having heavy sugar, eating heavy sugary snacks, we see that kind of dip in our blood sugar. That can really, really matter in how we manage the trauma and taking care of people. Of course, sleep is all important, and you tell your patients that as well as each other, but it is vitally important when you're treating people with trauma to work hard to regulate that sleep. If you need help from your physician, get it. Stress management, of course, I'm preaching to the choir here. We want to, of course, manage our stress as we're dealing with this work. But this will really depend on you and the kinds of things that manage stress for you. I personally like self-hypnosis. I got really good at it when I was learning to be a behavioral medicine psychologist. For some of you, it may be meditation, it may be music, it may be journaling, it may be taking a few moments to breathe, guided imagery. It can be a lot of different ways that we can manage our stress. But just like you would tell your patients to schedule it, tell yourselves to schedule it. These are your self-care resources. And then finding your joy, small moments of joy, paying attention to them. When something happens that brings you joy, focusing on it for a couple of moments, being mindful of that joy in your life. These are your self-care resources, which Dr. Figley says are directly related to becoming a resilient provider and finding compassion satisfaction in your work. They also lead directly to our confidence if we're looking at the stress first aid model. Let's go back briefly to these self-care resources. What did my patient do in that story? She found her joy. She not only realized what her joy was in the puppy, but she did what she had to do to be able to be mindful of that joy. She let that joy motivate her and be part of her own self-care, and it directly related to her confidence. Social support is another of the factors that Charles Figley says will lead to compassion, satisfaction, or resilient providers. This is also directly related to the stressed first aid element of connection. Those of you who work in this field, you know that the family and friends and colleagues that matter to you, who understand you, who understand the toll this work takes on you, are going to be lifelines when things get difficult. So it is extremely important, just like you tell your patients every day, to continue to really keep that social support network activated around you, to do what you can to grow and to nurture that network. It doesn't have to be a lot of people, as all of you know, but what is really, really important is to pull those people close to you and to keep them close. In trauma work, provider support groups or consultation or supervision can be part of that social support for you. Many times we think of social support as someone you can count on when you need somebody. That is the stressed first aid element of connection. So this is those people you can depend on. That can include colleagues, and many times it does include colleagues. Now, all of us know we're not really able to talk about the details of what our patients tell us to our family, are we? That's not what we're supposed to do. And many times we feel that it would be helpful to move some of those stories out of our hearts and into the air. That's what supervision's for. We are allowed to do that. We are allowed to discuss difficult cases, countertransference, the pieces of the story that are bothering us, the pieces of the story that we can't shake. We are allowed to deal with that in supervision, to move those stories into a supportive place where we can get that additional support from a supervisor or from a consultant. And that's the stress first aid piece of connection. Interestingly, my patient with her dog did figure out a couple of things. The dog led her to increase social support within her unit because they adopted the puppy together. But it also included for her an additional motivation of forward thinking of a social support network. She learned that A, the dog was important to her and was going to be part of her family, but also that she loved being with dogs so much that that's what she wanted to do going forward. So she was going to apply for the working dog program and become a dog handler. So she allowed that peace, that joy, to also help her connect with people around her that understood her. Whoops. So we're moving then into, let's talk more about that connection. So there are provider support groups where we are actually officially providing support and even treatment for providers who are dealing with vicarious trauma. These can look a variety of different ways, but it's important to think about this if you're a supervisor, that this might be a really nice thing you can offer those that you supervise, which would be more efficient for you as well, to be able to have this happen in a group setting. There's a lot of literature around the best way to conduct provider support groups, especially for those that are treating trauma, to be able to help them move that trauma outside of themselves and into a supportive space. Many times we look at weekly meetings as being the most efficient way to do this. We want outside facilitators, so we don't want the providers who are dealing with vicarious trauma to manage this themselves. We want someone else to be able to facilitate that so that everyone can really appreciate the work that's being done. These can become institutional rituals, actually. If a clinic is supportive enough, this really helps validate us, doesn't it? It helps providers understand that they've heard a lot about trauma, but that the world around them is not necessarily traumatic. It can be surrounded for them with people who believe in them, who trust them as providers, who understand that things have been difficult, but that doesn't mean that they're not going to be fine. Sort of a vote of confidence, if you will. So this can really be, those of you that have a lot of providers around you that are treating trauma, really think about whether this is something that you might be able to institutionalize around you, as a provider support group, It allows those trainees and providers, whether they're trainees or not, to know that the institution believes in them and realizes that sometimes it's okay to just have a chance to process some of this and to move through it, that it is difficult to listen to trauma all the time, and that's giving them a vote of confidence. Those groups can also really provide optimism. It can help people develop that optimistic thinking by being around other people who are going through it as well and hearing what they did to move through it. What typically how these go is that in provider support groups, we ask for storytelling. So what we're not asking here is for people to tell stories of their patient's trauma, but more of maybe a little bit of a summary of what kinds of things they've been dealing with, but then small successes, what kinds of things they did to be able to help their patients succeed. So yes, it's been hard to hear the trauma all week, but here's something I tried and my patient actually felt better, and it made me feel better. Or here's something that I tried for myself. Those self-care resources we talked about, those can also be shared in these storytelling, so that people can feel motivated and inspired by those stories. This gives you a chance to have some sense of healthy venting. Remember, I told you, or we were talking about how it's not really okay to share your patient's traumas with your family or friends, but it is okay to vent about something that you've been struggling with in a provider support group. That is the safe place to do that. It's also a place to find some humility around the culture that you're in. Being around other people who are experiencing those same situations and might have had some successes with trauma helps, I think, all of us keep a perspective. As providers, we are a culture. We are treating another culture, people who have dealt with trauma, and being able to be around other people who are doing it as well helps us stay humble, helps us realize we're not alone, and that other people have also had these struggles and have found ways to succeed. So I've got a poll for you. Do you believe that you need to understand what an individual has gone through in order to most effectively help him or her? So that's the first answer. Do you believe you need to understand what an individual has gone through in order to help him or her? So this is, in other words, do you need to be a rape survivor yourself in order to most effectively help a rape survivor?
So we'll have 30 more seconds to answer that poll question. So 44 responded yes and 92 responded no.
Okay. The second question is, do you believe sharing a traumatic experience could make you less effective? This is kind of the opposite. Not exactly, less effective. Sharing a traumatic experience could make you less effective.
We have another 30 seconds to answer that, and then we'll close that poll. Dr. Kraft, 38 responded yes, and 116 responded no.
Okay, great. So what these questions are getting at is the idea of shared trauma. So I'm going to be discussing a little bit shared trauma, what I mean by that, and this was just kind of a pre-question. Many times I'll speak to groups of providers about taking care of military people, and they will say, how can I possibly take care of a veteran when I'm not a veteran? Or how can I possibly take care of someone who has combat trauma when I haven't been to combat? And I'll often come back and say, well, do you feel like you have to have suffered alcohol use disorder in order to take care of someone who's struggling with problem drinking? And most of the times they'll say, no, I don't think so, or I don't have to be a rape survivor to take care of a rape survivor. But for some reason with veterans, people tend to get stuck on that. Other times, it is possible that people believe that that they actually might be less effective if they experience if they have experienced some sort of shared experience with their patients. So it looks like most of you believe that you do not need to have shared something with someone in order to effectively take care of that, and that if you do share a traumatic experience, you do not believe you would be less effective. Trying to go back to the chat here. Whoops. Oh boy. What just happened? Okay. There we go. So I saw that a couple of chats came in, and I wanted to make sure to look at them. I have a heart attack. My doctor will not have had to have a heart attack to help me. Yeah, well, that's a good point. Right. I appreciate the chats. This was the idea, was to kind of get your thoughts on, is it important to have lived through something traumatic? And many of you believe that it's not super important, but if you have, you're going to be okay. And that's typically the way we see it in the literature. You kind of see that the idea of shared trauma is one that has a lot of gray area. I put this quote in here that it's in one of Charles Figley's books, and I thought it was beautiful. You can't describe it unless you've seen it, can't explain it unless you've done it, can't imagine it unless you've been there, then it never goes away. What do we mean by shared trauma? Shared trauma is a situation in which the provider and the patient have similar experiences. So Dr. Figley was the one to first coin this term after Hurricane Katrina, when he had lived through Hurricane Katrina, but then he was taking care of the victims of Hurricane Katrina. And many of the psychologists who were called to do psychiatric first aid after the hurricane, of course, had lived it themselves. Their houses had also been affected, their children, their schools, their workplaces. This was their city, and it had suffered a great disaster. And so how much did that affect the provider's ability to take care of these victims? And he believed that in some ways they were very effective because they had lived a similar experience. They really understood, and there was no need to have to explain. On the other hand, there was this idea of cumulative exposure for the providers, not only having gone through it themselves, but also then hearing about it. So what he found was that providers did experience unique reactions to taking care of those that had lived through the same trauma. Those that came from those communities did seem to have an additional burden placed on them, or a cumulative toll, if you will, that took place because of their personal experience as well. Many of them provided outstanding care and felt that they got to skip multiple steps with their patients. In other words, they didn't have to ask about what that experience was like because they knew it, and the patients knew that they knew it. So there was a lot of expedition. The care was able to be expedited. But on the other hand, it accelerated that idea of cumulative toll for the provider. I'll share with you a provider support group study or story. This is again from my book, and it's one of my favorite chapters in the book because I think it illustrates a provider support group that we didn't even know we were doing. But B, it talks a little bit about that shared trauma and about how that took a toll on us. It's especially important to me because the captain, the Navy captain in this story, did go on to become a mentor of mine and one of my most trusted supervisors from my Navy career. So this is for him. This is our surgical company, Alpha Surgical Company, outside the side of the hospital during 2004, during the first battle for Fallujah. And this is a chapter called The House of God. The Navy medical officer for Naval Mobile Construction Battalion, a Navy captain, happened to be a psychiatrist. Jason knew him from his time with the Marines, and I knew him from my aviation tours. We both liked and respected him. A short time after we conducted those marathon debriefing groups for his CBs, Captain Kaufman contacted me to say he would be visiting our base to check on his battalion, and he asked to meet with Jason and me. He also invited Gary, the psychologist assigned to the Marine Infantry Battalion on base. Gary operated in isolation most of the time due to the frequency of his Marines' missions outside the wire, which was off the base. When I imagined how difficult it would be for me if I were in his place, all alone, I worried about him a little. When the captain arrived, the three of us were waiting. He wore the uniform of the Seabees. We entered our small office space and closed the door, taking seats that faced each other. So Captain Kaufman began, making eye contact with each of us. Since I was here anyway, I wanted to use this opportunity to check in with the three of you. Having expected questions about the Seabees, we sat in surprised silence. You've been here over 2 months. We nodded. How are you doing? He spoke the words deliberately, dark eyes focused intently on us. We glanced at one another, shifting in our chairs. I cleared my throat. Well, I think we're fine, sir. Clearly unconvinced, he moved his eyes to Jason and Gary, who nodded in earnest agreement. What sorts of things are you seeing most? We were ready for that one. We knew the number of patients our little clinic had seen, the diagnosis categories, and our medevac numbers, which were low. These Marines, they don't want to be sent home, we told him. Nodded. So we tend to keep them out here with us. Is it mostly Marines you're treating, he asked. What about the medical providers with you? Are you able to help them process some of what they're witnessing? Jason and I laughed. They don't want anything to do with that, sir, Jason said. There was one case we dealt with, a little girl. Pretty traumatic for everyone. After that, some of them asked to talk, but for the most part, everyone's doing okay. At least that's what they're telling us. Do you believe them? I don't know. Everyone seems like they're hanging in there. It's been a long couple of months. How are you dealing with it all? He asked. Not unlike the way our reluctant patients often looked at us, we sat quietly and stared at him. 4 shrinks in one small room, I mused in silence, hiding a tiny grin. Someday, I imagined, I would look back on this moment and chuckle. How are the Seabees doing now, sir? Jason asked. The captain smiled a little and took the bait, thanking us for our care of the Al-Assad battalion. Happy for Jason's skillful deflection of the senior psychiatrist's attention, I mentioned that Jason and I had attended the Seabees memorial service, adding I had not realized how much I missed our national anthem until it was played that day. I think I said something about that moment, the sudden appreciation of the Star-Spangled Banner, being one I would never forget. The captain asked about other moments we would remember. Jason and Gary paused, so I jumped in. I told him about Dunham. I intended my story to be brief, focusing on the clinical details about the changing status of his head injury and the strength of his spirit. But somehow it ended up about us, about our connection with our Marine, our delusional hope he would recover, about the crushing news of the death we all knew in our hearts was inevitable. I felt tears pool in my eyes and blinked at them angrily. Oh, for Pete's sake, I muttered, mortified. I mean, how many times have I told this story? What is wrong with me? The captain smiled kindly at me, saying nothing. Gary started speaking then, surprising us all with a vivid description of a horrific scene at which he arrived as a first responder. My own embarrassment forgotten, I leaned forward to touch Gary's sleeve. I wish you would have come over, I breathed, searching for eye contact. Please, Gary, don't go through something like that alone again. We're right here. He looked up, eyes misty, and smiled slightly at me. I knew he wouldn't ask for my help, but he appreciated my offering it. And so it began. We talked about casualties, about the strain of listening to the grief and fear and loss of our patients all day, every day, about sometimes having no idea what to say, about the incoming rockets and the baking heat at night, and the contractors we watched beheaded on video. Most of all, we talked about fatigue. We were tired, we told him. We'd only been out here 2 months. Captain Kaufman listened to us for almost 2 hours. When he left our office that day, offering to drop Gary off at the regiment, Jason and I sat in a moment in silence together before we looked at each other. Well, that was interesting, I said. Jason nodded. That was group therapy, that's what that was. You know, I commented as we rose to gather our covers and sunglasses from the desk. I'm wondering if Captain Kaufman really came out here just to check on the Seabees. It was pretty clear he was here today for one reason, Jason said. He was here to check on us. Later that evening, writing in my journal about our cathartic group, I remembered a book I had to read in school, The House of God by Samuel Shem, an entertaining and heartbreaking story about medical interns, had almost nothing to do with our experience out here, except for one character's words, which popped into my mind now. He said, "How can we care for patients if nobody cares for us?" We never forgot how the captain cared for us that day. Oops. So, what I've done there, I think, is perhaps illustrate for you a provider support group. It was one that was impromptu, that came together without us thinking it was going to, but ended up being something where we were able to tell stories, where we were able to vent about what was really tough out there at the time, about what had kind of turned into shared trauma for us. We ended up taking care of Marines all day, only just a few of us and an awful lot of them. And we heard about the things that were traumatic for them. We heard about rockets, and we heard about people getting injured and dying, and children involved. And it was the same things we saw, the same things that we experienced, and the same things we heard. I think for us, it ended up being a chance to let some of those horrible images and some of that personal fear be aired into the room between us. It's different, of course, because you're not conducting provider support groups in a combat zone. I hope you're not conducting provider support groups in the middle of a shared traumatic experience, but someday you might be. You and your colleagues or supervisees might have lived through something similar if your clinic or hospital or community experiences something. But even if you haven't, the ability to get together and allow for a safe place for storytelling and for the inspiration to be shared so that together you can talk a little bit about what kinds of things work for you, what kinds of things are helpful for you moving forward. That's really vital for people, and it gives them permission to think about that, to think about their self-care resources, to think about the ways that they can bring those internal confidences to the table so that they can move on, to move through some of this and into the world of providing satisfaction, to being resilient in the face of trauma, and to experience the true satisfaction and joy that comes from having compassion for your patients, from treating trauma, which it can be a very rewarding work. It's just incredibly important to allow people that opportunity to move through some of that. There's a specific kind of provider seminar, provider consultation group or support group, which has come to my attention recently, and that is a support group that focuses on clinician survivors of suicide. This is kind of its own special small literature that has only recently begun to show up. And there is some new and emerging work that's being done specifically out of the VA about the toll that patient suicide can take on clinicians and how that can be its own kind of trauma and vicarious trauma. So there are some new and interesting ways of thinking about provider support groups as they relate to being clinician survivors as well. So while provider support groups can be general and can just be allowing for storytelling, there's also the ability to bring people together who have perhaps survived a suicide of a patient in a clinic or in a hospital setting or in a training setting. Remember that can be a specific focus of your provider support groups as well, if needed, because that's a specific clinician trauma that is important to pay attention to and to address. But overall, the ability to allow clinicians that permission to speak, the permission to talk about their self-care and their attempts to try to find optimism and find joy in their work, it can be very validating for people, and it can give people motivation and inspiration to be able to find their own way. This work can take its toll. It can also be amazing. So please know that whether it's individual supervision or provider support groups, there is a fair amount of evidence now around the ability to help people move through vicarious trauma and to continue to provide outstanding care for their patients, even despite the fact that those patients have lived through trauma. I have here photo references. Many of our photos came from military websites, as well as my personal pictures. And then for your information, the references that I used here, as you can see, a lot of Figley's, as well as my memoir there that I read you from. That's been a while since that was published, but I still like to use those case studies because they're so personal to me. And some additional resources for you. Our courses that you saw clips from are hyperlinked to the PsychArmor website. Very quick and easy. There's CEs available for some providers in those resources, as well as some additional resources for you to be able to move forward there. And I hope to be able to take some questions now. Let's see, what do you think of the professionals that work on the National Suicide Crisis Hotline? Oh my goodness, yes, we've actually had a chance to talk to some of those, folks, and they do they have supervision in place so that as they work on the suicide prevention national crisis lines, they have supervisors that roam and are able to do one-on-one debriefing as needed, and I think they actually schedule it as well, so it's not even just a PRN thing. They actually have individual supervision scheduled so that they make sure to have a chance to debrief and to allow those experiences to move through and out into the space between them to get a chance to talk through that. But I know they also do provider support groups. They get their groups together and talk through shared experiences, what's been working for them to help them stay resilient and to move through that, what can be very traumatic, obviously, as you can imagine. Do you use EMDR with trauma survivors or clinicians who work with them? I personally am not trained in EMDR. That's not because of anything in particular. I got trained in prolonged exposure and cognitive processing therapy, and I have been using both of those with my military patients. However, many of the folks that I've supervised are trained in EMDR, and many of my colleagues are trained in EMDR, and they love it. I've had some patients that have used EMDR to move through PTSD, and they really liked it. So it's all about the ability to use this external stimulation, bilateral stimulation of some sort, whether it's tapping or eye movement, that allows the person to release that cognitive constriction that happens in trauma and be able to access the memory. What are your thoughts on TF-CBT? I do not know what that is, I don't think. TF. I'm not sure that I know what it is. If you could tell me what TF stands for. I'm very familiar with CBT because everything I use is CBT, but does it stand for trauma-focused? Oh, trauma-focused, okay. Well, to me, trauma-focused is a way of life. I think from a trauma-informed lens through everything I do. So what I tend to do is if I have people with PTSD that actually fit criteria for PTSD, I use one of the evidence-based protocols for that, either prolonged exposure or cognitive processing therapy. I think that trauma-focused CBT is just the use of CBT principles through a trauma-informed lens. I don't personally know of any certification in TF-CBT. There may be something, but as far as PTSD specifically, if I were treating someone with PTSD, I would get trained in either EMDR, CPT, or PE, since that's where all the real evidence is in the treatment of PTSD. As far as taking care of each other, vicarious traumatization, I think we like to just think if we can look at people through a trauma-informed lens, assume that people have been through something, and never assume that someone has not, then we can go forward with CBT just knowing that. Can you speak on somatic experiencing? I'm not sure that I can. I think that I understand what you mean about after trauma, people have physical symptoms that are the way that the trauma is manifesting in them, and we certainly would experience physical symptoms as part of a trauma experience. They can often accompany PTSD. They can also accompany secondary traumatic stress that providers experience. People can have headaches, muscle aches, GI problems, fatigue, a lot of somatic manifestations of the cumulative effect of trauma. That is when I take care of people who have PTSD or providers who are experiencing compassion fatigue, I often am focused on helping pay attention to those somatic symptoms and assuming that they're talking to us, that your body's trying to tell you something. So as we treat the larger picture, as we help people bring their self-resources to the table as providers and work to find that optimism, work to find that social support, that we can help those somatic symptoms tend to resolve as the other symptoms of trauma exposure resolve. Other questions?
There is one more question, Dr. Kraft. Beginning this November, all nursing homes in the USA must care plans specifically around trauma history. Any specific recommendations for nurses and others who work in geriatric settings as they attempt to provide person-centered, trauma-informed care?
Well, that's wonderful news about the nursing homes needing to include trauma history. That makes me super happy. I just spent a couple of months with my dad before he passed away in a variety of skilled care facilities, and it was really important. I would have been really important for them to know his trauma history, and I know they're very, very busy. So nurses in those skilled care facilities are the busiest people in the world, and I feel for them. But I do think it allows them. Remember, we talked about burnout, how people get kind of experience depersonalization. I think learning about a trauma history of your patient, as opposed to not knowing that at all, will provide nurses with the opportunity to keep that personal connection a bit more. I think that while we do run the risk of a little bit of additional exposure for those nurses, if they can maintain their self-care practices and maintain some supervisory and provider support groups with all their nursing staff, if at all possible, I think it will allow them to provide better care because it will allow them to connect with their patients and provide that connection that we know matters in trauma. As far as specific recommendations, pay attention to your self-care, make sure to keep connected with your fellow nurses, with fellow providers, get that support group going once a week, and so that you can allow that additional information about your patients to be used in a positive way and allow you more compassion satisfaction and protect you from having that move towards compassion fatigue.
Yeah, just one more question, and then we'll wrap it up. How do you treat complex PTSD versus PTSD differently?
I don't know that I understood what the last initial was. PTSD, I heard you, but what was the first? PTS what? Diane, can you just tell me what the two initials were? One was PTSD, like Delta. What was the first one?
Complex PTSD?
Versus regular PTSD?
Yes.
Oh, okay. Well, the treatment is the same. You still use one of the evidence-based treatments for it. So either cognitive processing therapy, prolonged exposure, or EMDR. Those are the three that are based in evidence right now. There's a lot of additional exciting things coming down the lane, and there's evidence building in many other treatment modalities, but right now those are the three that have the evidence behind them that they work. The treatment is the same. It's just a matter of, as you're hearing the story from the patient and as you start to put together the different places from which the patient is pulling that narrative, sometimes you'll have that moral injury, that piece that is kind of difficult to navigate. There may be survivor's guilt, shame and blame, other things that make the story more complex. So as a clinician, that's going to just be what you navigate as you go through the protocols. Each of those protocols has the ability to expand as the trauma narrative gets more complex and as the presentation gets more complex. So they are all well equipped to be able to handle any presentation. Just sometimes it might take a little longer.
Thank you, Dr. Kraft, for your time today and your expertise in experiencing and sharing with us today. We are now going to conclude this webinar. Your browser will take you to an evaluation on VADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. You only can register as a visitor. So for CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link when you set up your profile in VADA's system. This helps connect your attendance and your profile. You will want to and highly recommend to use the email that you used to sign up and register for this webinar. That's the email to create your VADA profile. You will get a second opportunity to complete the evaluation through a follow-up email. The sender will be Messenger at WebEx. So please make note that it will be from Messenger. Evaluation will close at midnight on Thursday, September 26th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation.